So some controversial things, compartment syndrome, the use of the new device that Dr. Harvey was talking about, aspirin for DVT prophylaxis, that's all different than previous. Yes, Dr. McKee.
So, Ed, we have a fair number of patients who come in found down. Found down in the desert is a bad thing. And, you know, the tight swollen leg, and it's a major issue for them. So what do you think for those patients who are found down? How does the device help, and general thoughts on that issue?
Yeah, it's a good question. We designed the device for trauma. We have pivoted into the ECMO vascular world, and the found down, we don't have as much data. I know Tim put two in, and one found down patient in Reno that helped them vastly avoid fasciotomies. Is that correct?
Yeah, that's correct. Yeah. I'm not, you know, once again, numbers are really small, but I think in the general practice of orthopedics in communities, I mean, the indications to do
Microphone.
indications on.
Is it on?
It's on.
They're recording.
Here's Ed.
Here we go. Yeah, I'm sorry. The indications in private practice or in community practice to do fasciotomies are pretty low. I mean, I think because of the liability involved and to miss it, I think we have a tendency to do way too many fasciotomies, and so we're looking forward to, you know, any kind of advanced technology.
I guess my specific question would be, like, I don't want to do a fasciotomy in a leg that's dead, because then you end up with an amputation. I think there's evidence to support that. If you put a mile 1 into someone who's found down and the leg's already dead, what do you see? Do you know? Does it help you at all? Or what are the numbers like? They decode.
Yeah, so you see a high value, it doesn't change. You had a case where you put it in, what I never would have put it in, was patient was a day out and had a pressure of 90. And to me, I would have said, okay, that's dead. But then you continue to watch it. That's why trend's important. And it went up over 110. Your logic, if I can speak for you, which is really hard to do, is that muscle was dying. If the pressure was going up, muscle was dying. And you went and released that guy and saved his leg. So I think that was a great example where trends are more important than the number.
So it'd be safe to say if you have a guy found down and you put the mile 1 in and it's like 70 or 80, and it just stays and it doesn't go up, it just stays or slowly drifts down, you would leave that leg alone, is that?
Well, it's the perfusion pressure actually that makes the big difference. So yeah, if the perfusion pressure is 0 and it's been 0 for 12 hours, I think I'm not opening that.
I think maybe just if they're found down over 24, 40 hours, just don't put it in.
Yeah.
Because if you put it in, I mean, you're obligated to do something or comment on it.
Well, in the old days, yes, but if we had information that was accurate, saying that this is when a leg is already dead and you should cut into it, that would help us in the long run, because often you don't know the history. That's the
We're starting to pull back data from Ukraine, actually, where they're using it for tourniquet disease, because people, despite using tourniquets, they're forgetting to write the date and the time they put the tourniquet on. So patients are coming in and we have data from multiple sensor sources, so we're going to have that data in the future for sure.
Thanks.
Yes. Dr. Schmidt.
This is a really important question because, you know, fasciotomy is only of benefit when it's properly timed. You know, too early, you're subjecting the patient who may not have needed it to all the morbidity, but when it's too late, you know, everyone talks about compartment syndrome causing death and sepsis and all this stuff, but it's actually the late fasciotomy that causes those things. You know, our clinical practice guidelines, which we're kind of updating now for the academy, talk about hard, you know, dense nerve palsy, so someone's completely insensate and has no motor function. That's a sign that it's progressed far beyond the potential for fasciotomy to benefit. And another thing that I think there's a lot of misunderstanding about is the renal impairment. So I've heard a lot of my general surgeon and medical colleagues say, well, this person needs a fasciotomy because they're in kidney failure and they're going to kill their kidneys. But the kidneys always recover. We looked at about 30, 40 patients of ours that were found down, and some of them even had to have dialysis. But it's important to know that the kidney function recovers, and that's not a reason to do fasciotomy. And in fact, if you do a fasciotomy in that setting, you can actually cause, you know, sudden release of electrolytes and other things and cause, you know, acute cardiac arrest and all sorts of bad consequences. So it's something to be really careful about.
No, I think these are all good points, but I think you can think of it in this way. What we had before is BC, and now we have AD. Yeah. And that now we have data, and before we didn't. And, you know, and that's what all the myths, we're busting a myth every week, basically. So I think going forward, we'll have a lot more data, and all this will come out, especially with the use of AI in the back end is coming.
Other questions? I actually had a question for Dr. Schneider. So the Prevent Clot study, they've done multiple variations of it, presentations. So the latest one was even in a high-risk patient, aspirin is non-inferior. But then I noticed in your chart that you had, you who were actually recommending, for high-risk patients, you were recommending low molecular weight heparin
Or aspirin. So
or aspirin.
yeah, so great question. One challenge with, I think, evolving literature is that it evolves.
Right.
And so this algorithm at the time, so it was probably about 18 months, so that data hadn't been presented or published at all. In fact, that data is very recently published. So I think that current best evidence for any patient is that either can be, I'm going to try to choose my words very carefully here.
Never say always, that's what you said.
Correct, yeah, exactly, are good options. And I think that what I would really love people to take away is that that doesn't mean a population-based approach, doesn't mean everyone gets aspirin or everyone gets low molecular heparin. I think there does really need to be a personalized approach, at least to an extent, of looking at things like an oral anticoagulant is cleared by kidneys, so you need to know their kidney function. Antithrombin is the target for low molecular weight heparin, but trauma patients actually have antithrombin deficiency up to 30% of the time. Aspirin allergy is actually very real, and patients come in with thrombocytopenia. So it's really not a blanket statement.
So if someone doesn't have an aspirin allergy, trauma patient, is there any time when you wouldn't choose aspirin and you would recommend low molecular weight heparin?
So I would still say, and there is data coming out that may go against this, but it is not out yet, the patients with an intracranial bleed and a spinal bleed are still patients that I think we have to be very wary of. And the reason is antiplatelet agents are irreversible. So you inhibit that platelet, it is essentially completely inhibited for at least 7 to 10 days. So I think we still need, with the available evidence, to be careful in those particular patients.
But I think there's clear-cut evidence for hip fractures, your
Absolutely.
isolated orthopedic trauma, aspirin's enough. And I mean, I personally have a lot of patients who can't afford low molecular weight heparin or anything else. So you might discharge them home with it, but they're probably not taking it because a lot of them can't afford it.
Absolutely.
Aspirin's cheap and easy. Okay.
Probably already addressed it, but what happens when you have a patient coming in that's on aspirin, broken hip?
Yeah.
If we started giving them platelets, we've had almost no transfusions, and we don't have to wait. I may be doing something off-label, but that's what we've been doing with people that are on oral anticoagulants.
Okay, so I just want to clarify your question. So antiplatelets or oral anticoagulants? I apologize.
Aspirin.
Aspirin.
So someone who comes in on
Perfect.
aspirin.
Yeah, so the nice thing about platelets is they're also regenerating every moment as we're sitting here. And so you've inhibited those platelets, and of course they cannot regain their ability to aggregate. However, new platelets are forming every moment. And so you're absolutely not doing anything wrong whatsoever. Bleeding may be slightly increased because the platelet aggregation is inhibited in some of your platelets, but you're doing everything right. And what I would say for thromboprophylaxis in those patients is there is fairly good data out of the UK that low-dose aspirin is actually up to 160 milligrams. So baby aspirin are up to 160 milligrams, even on top of what they have, is still considered low dose and would be in agreement with the Prevent Clot trial.
A high percentage of the patients that come in with hip fractures are on some kind of an anticoagulation program. And I think we operate pretty much on everybody. And just like we were talking about, like, I just wouldn't use a spinal. But other than that, I think you can just go ahead.
So that's another important point. Don't delay surgery because they're on Lovenox or Xarelto or whatever the latest craze is. Like hip fractures need to get surgery within 24 hours. There's lots of evidence for that. Don't delay surgery. And I know there's still some hospitals that push back. The anesthesia team really pushes. And so there's lots of literature out there that you can fight this at your hospital. I think Dr.